goes over two joints, okay? At least two joints or more. Two or more joints, okay? You can get either active or passive insufficiency. Okay, so the example in the book is I can squeeze my hand here, okay, and what muscle have I put on a stretch? What? This, right, I'm contracting the flexors, I'm stretching the extensors, right, because I'm going in the opposite direction, okay? Now, if I take that and put it even more on a stretch, my hand will naturally lose the ability to hold a tight grip. Why? Right, because this muscle, these muscles actually, this group of muscles, are not long enough to allow both to go on at the same time. So it's an insufficiency. Now, there are two different types. There is an active insufficiency where I am contracting, right? I'm actively contracting, which is not allowing my hand to close because it's lengthening this too long. So there's an active action going on. Passive insufficiency would be if I, as a therapist, came to Katie and did the same thing to her without her actively contracting anything, and I start to stretch her and her hand starts to kind of pull loose as I pull her down because it's still an insufficiency, right? But she's not actively doing anything. I am doing it for her. It's passive. Does that make sense?
Can you use that principle to gain like more leverage on a stretch?
You can a little bit, and that's why in your notes and even in the little presentation that I made you guys, it talks about that you start with the more distal, okay? So for here, if I'm trying to stretch somebody's hands and they can't do this, and they can't like make a ball with their hand, I know I need to stretch the extensors, right? Because they're the things that are tight that are holding this hand back from getting the full range of motion. So I would start with the hand, but then if I have them start stretching here and I add that, it's going to add even more to that. And so that's why they say on two joint muscles, start with the most distal, get that going first, then add in the extra, and you'll get an even better stretch.
What about cranking the ankle into dorsiflexion during a hamstring stretch?
You can actually add that, and it does help a little bit because of the way the gastrocnemius and the knee and everything kind of interact. Just know that. You can get even a little bit more stretched out. But that's kind of an unusual situation. Okay, I just wanted to make sure you guys, does that make sense? Okay. Any other questions? All right, so real quick, just want to talk about this. I will get it printed up and ready, but I'm going to move everybody in group 1 for Wednesday up 1 because unfortunately Kim is no longer in the program and she was going to fill that spot. So Martina volunteered to go at noon, which means Crystal goes at 1 and Jacob goes at 3. I know Crystal's not here, but we'll let her know, okay? So just know that. Okay, so Jacob, you're going just an hour earlier. Martina is going an hour earlier. Crystal's going an hour earlier. Everything else will remain the same on that. So, a few things before we get started with your last few presentations. Making a mess here. Okay. So, no phones or anything. I'm just going to show you just really quick a little bit from one of the practicals, okay? Because Thursday, we're going to,
Don't film it.
yeah, don't film it. Does that make sense and help? Okay. I just didn't want you to go into the test and go, well, this wasn't on our mock scenarios. You're right, it wasn't. But if you know your ranges of motion, it'll let you know that. And on your mock scenarios, it does tell you pick 1 or 2 areas to stretch, and it does give you that. I just wanted you to know there will be a chart like that, and that actually fits more what a real eval from a PT will look like. Okay, what else did we need to cover? So, where are we? I have up here the presentations from last time ready so that when we're done we can practice them. I will copy off today's. These are the original. If you haven't gotten these yet, come up real quick and I'll give them to you, okay?
Would that be what I got on Thursday?
Mm-hmm.
Okay.
There you go. They might not be super pretty and lined up, but you can do something. Come on. There you go. Oh, look at that. I nailed it. That's awesome.
And I'm writing that right now.
Okay. That's fine, and I'll,
We just made it flow a little bit better. Plus I saw your Nerf Glide video last night, so I was gonna add that in there.
and I did put up videos for each of these. Just as you're studying, if you want a little further information or some other ideas on some exercises, there are videos up for each of these now. And I'm already partway through lower extremity and trunk ones. And as soon as those are ready, they'll be up and available to you probably by the end of the week. Well, actually, no. I set it to where they won't post until the Monday after your practicals, so you don't stress and worry about it. Okay?
And what was that for?
But what? They're just videos on each of the different injuries and surgeries and ways to treat them.
Yeah,
So
Dr.
how-
Joe's pretty funny. She's silly.
I like Dr. Joe.
So help clarify this with us, was on that scenario, the extension was limited, so they're not able to extend all the way.
Right.
So that means
Their biceps is
biceps are
tight.
tight.
Yep.
And so if it was the opposite way, if they weren't able to flex all the way, that means that the extensors are tight,
Right, which would be
the like triceps.
Yep.
I did about that one.
So you just have to think of it, but like, there would be, it really is an insufficiency in the biceps then?
right. There's insufficient movement in the bicep. Right, because it's bound up for
It's
whatever.
making extension not possible.
Right.
Okay.
And that's why infields become really important, because if you're trying to extend somebody's bicep and there's no hard infield, there's still a little bit of bounce there, and it's got that open or leathery, well, the open is pain, but it's got that leathery infield, then you know there's still room to give, and it's because this muscle is tight.
Insufficient.
Oh, I gave you double of that?
Got them all in order.
There you go. All right, so
Got 'em all
everybody
in
should
order.
have those. And this today, as soon as everybody's done, we'll take just a real quick break before I do other stuff, and I'll print all these off and give you the rest of them, so that we should have a pretty good idea once you've gone over them, how to treat each of them. And with the rest of today, after that, we'll just practice 3 or 4 or 5 of these, so that you guys get a feel for that, and I'll give you guys instructions on that before we go. Okay, before we let Eric get started, I want to show you just a couple things in the notes that are important. Most everything we've really gone over. Make sure that you understand, though, here in the book, the different stretches, okay, hold, relax, but understand rhythmic initiation, contract, relax, rhythmic stabilization, alternating isometric, slow reversals, okay? Make sure you have those kind of understood and down.
Are those, is that from Canvas notes or from?
Just from the Canvas notes will give you enough, and I don't mind going over them again with you guys.
Is this something we would do in a practical?
What?
Is this something would we be doing rhythmic stabilization like in a practical?
You might, if you deem as a therapist that that's the best way to treat whatever situation you got it going on, sure. Yeah, that's the whole point of really studying those, is so that you have a few more tools in your belt to have options as here's an exercise I could do with this patient to help strengthen whatever. Okay? So there's not really much in the forearm section that you guys shouldn't already know. Okay, and we're gonna go over those few treatments that are there. Why is this off? But in the hand section, there is a module I want to go over just real quick with you guys because it's a little bit different. Okay, and it is important for the test. So, when it comes to the hand, you just need to understand there are different types of grips. There are mechanical or power grips. A power grip just means it's using all the fingers and the palm in opposition of the thumb. Okay? So if you look at, and there's different grasp, a cylindrical grasp, kind of like you would hold a baseball bat, okay? Except with both. Okay, so what's going on there is all four fingers, my thumb in opposition to that, and my palm is involved. Okay, it's a power grasp. It involves basically the entire hand. A ball grasp, same things going on. Okay, I'm grabbing the ball, my thumb is in opposition, all four fingers and the palm are involved. Okay. Hook grasp is picking up like a bucket and the lid, same thing. It's basically almost a cylinder grasp, except what you're pulling is so small that you're really more hooking. Okay. And finally, plier grasp, same thing if you're doing a pair of pliers, palm involved, all four fingers, thumb in opposition. Okay. Then you move into what are called precision grasps. So there's power grasps and there's precision grasps. Here are your precision grasps. So if I'm picking up like an SD card or even this pin like this, okay, this is called a pulp to pulp because this part right here of your thumb and forefinger are called the pulp. Okay, so if it's like a little bird, a little cheeping bird, that's pulp to pulp. Okay, and that's a precision grasp. The rest of the fingers are not involved. The palm is not involved. You're not going to get a lot of power at that. It's more for precision type thing. Lateral prehension. Okay, I am taking the pulp of this and going to the side, the lateral, which is, it says lateral, which is weird. It's actually the medial side of this finger. And it's just like I'm kind of pinching this to hold it. Okay? Makes sense? Then tip prehension. I'm just using the tip, so I'm trying to like pick up a needle or something really small and I'm just squeezing the tips. That's tip prehension. 3-fingered grasp, okay, something a little bit bigger. Thumb and your second and third tips together, okay? And then the final one is just 5-fingered, okay? This one is the only one I think might be a little confusing, but, okay, I grab this ball with just the tips of all my fingers. It's still not a power grasp. Why?
Because you're not involved.
Because the palm's not involved, okay? It's not allowing me to get full power on it, it's just the tips, okay? That's the only one I think is a little confusing. So, on your midterm, there will be a section of matching, and it will say 3-fingered grasp, and it'll ask you to match it to either a power grasp or a precision grasp, okay? So you need to be able to know what each of those are and which type of grasp they are, okay? And that's really the only thing that's going to be outside of stuff that we're going to learn kind of today. All right, I will now yield the floor to Eric first.
Got your music, Eric?
Dun, 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 dun. Okay, that's fine. I will make it front and back when I do it.
So, this is a slap fusion repair, and it's kind of confusing, really, a slap, really to know what it is, a slap fusion. And on the front of the
Glenoid.
glenoid, where the joint sits, then there's the labrum that goes around it, which is cartilage, and the biceps tendon attaches at the top. And so anytime that there's fraying or tearing or a separation with the bicep tendon that involves the labrum, and so there are different states of that. That's what that is it's a tear, and it affects how the shoulder is held into place in its socket. So the important thing with this starting out in phase 1 after the surgery, really the first thing you want to do is no more harm. So the goal there is to protect the shoulder from and the biceps tendon from further damage. That's by going into a sling, and also the objective is to activate the muscles. So it's a really it's a really mild treatment in the first phase. Really, the best thing you can do is not make it worse. So we've got sling immobilization is brought into there, and as a precaution, or one of the things that happens also is that the axillary nerve tends to have hypersensitivity, which is just where it feels weird or there's nerve pain involved, and so it comes up later, but they do that, desensitize that nerve by rubbing that area with different textures. The area of the skin that's involved, just silk, or drag a fork gently over it, or a rough material, just anything that's going to give different textures to that area. It kind of wakes up the nerves and reminds them what they're supposed to be feeling.
It's called desensitization. You guys will learn more about it in 210. But when a surgery is done, they can't help but cut nerves. Okay, and so what happens is as those nerves try and grow back, it can be weird and uncomfortable feeling. And so what you can do is you just kind of start with just like light, gentle brushing, and then you kind of move to a little bit more aggressive things, kind of like rubbing a fork, or there's different things you can do for that. like brushes and different things that you can start kind of rubbing on it, just to get the body used to feeling sensation again, because it can even get painful because the body just is reconnecting with those nerves, and it doesn't know to understand sensation and what's going on, so it'll interpret things as pain. And so you kind of just walk them through slowly a progression to where they kind of get used to touch and sensation again.
I was trying to use my phone to get. I'm just going to use this.
Sure.
As my. Okay, so really for 6 weeks you want no tension on the long head of the biceps. You really want to isolate the biceps, and that's the sling. That's going to be the actions that you take should really leave the bicep out of it. That's for 6 weeks, pretty much. No resisted supination. Again, that's going to involve the bicep elbow flexion. Shoulder ER is limited to 40 degrees for the first 4 weeks. Avoid abduction in ER for 6 weeks. No extension or horizontal abduction past body for 4 weeks, and forward flexion past 130. So as you're doing these, they kind of present it like, well, you want to do these stretches, but keeping in mind those limitations as far as timing or the extent of the stretch. Range of motion, active assisted range of motion for elbow and wrist, and that's kind of working the surrounding areas while you're not working the ones that are going to be too sensitive. Gentle passive range of motion for shoulder flexion, abduction, IR, and ER. Any of this, if there's any pain, then stop. That's the main thing. So this is done. We saw pendulum swings, passive range of motion with the ball, and that's going to be.
Oh, I forgot to get.
I think we may have gone over that.
Talking about the big one?
Yeah.
Oh, I forgot to get it out.
So then if I can have a volunteer who would like to visualize passive range of motion with the ball. Anyone?
And this isn't actually one we went over, so
Oh, so you can start out here and just let the ball extend that, stretch that out, and then you can also lower your shoulder or bring your trunk down. So yeah, just let the ball stretch it out. And you want to not engage the shoulder really.
right. So the key, the key there is just make sure that they're kind of moving their body and maybe even backing away from the ball, like with those walkaways that I showed you, so that they're not actually pushing the ball necessarily. They're just kind of extending the arm on it. Does that make sense? To where it's truly a passive range of motion.
Once they get to that active assisted stage, could you have them put the other hand on the ball and like move that arm to
Yes.
move the?
You can also use the other hand to control it so you don't engage, but you're just making sure doing that doesn't make you engage the muscles.
Right. And the thing is, and one thing just to kind of note, and Bob and Brad, one of the videos, at least maybe a couple of the videos. So if I just have here, and they're kind of bringing their body into it, you see how I'm not actually moving my shoulder, right? And you can get to, at this height, a little above 90 degrees, okay? So you can just kind of control that by the height. If they're getting better and you're further along in the process, don't look. You can have them sit down and then look.
Yeah, you don't want to go past 130 degrees
It
there.
just
for quite a
increases
while,
it.
though.
Right. So just know that. But I'm just some kind of tricks. And Katie made a good point though, is that if they've hit that active assistive range of motion, just so you know, another good exercise is to use the other hand to push the ball to where they can start kind of engaging those muscles in all different kinds of ways. Okay?
Similar one to that is if you'll have a seat here, And you can set your arm on that. Actually, I think. And then as you sit forward, just let that slide and stretch it. And this would be actually probably past 130.
Right, and so you control that just by lowering it.
It's actually at this point, I think it's 100 degrees. It says 100 to 130, but I think probably staying around 100 at this point and then phase one. But you can use this exercise on out to 130 later. And really, that's something you can go up to 180 if you
Right.
further on. So the submaximal shoulder isometrics, you went over that, and that's just using you can place a towel, if you'll stand up, sorry. Place a towel underneath your elbow or between and that's just to keep it from really going anywhere, and then you can go up to a door and do ER, IR, shoulder flexion. And then with this one, you can lean up against the door for extension or flexion, extension. And then the only one is that for one of those.
Shoulder abduction.
Yeah, I was trying to think which one doesn't work with the door.
Yeah, shoulder abduction is the only one you can't really do with the door. You just fold up a towel or put the ball in between their body and their arm and then have them squeeze that way. Because there's no way to really get in between, like the door in between. So the key with those submaximals is just explain to them this is a really light isometric or muscle setting contraction. Very light. You're not pushing as hard as you can. You're just barely kind of pushing against it. Just pushing against it.
That's our Texas side coming out.
Yeah, it just slipped out. So just know that it's just them. Just explain it's just to kind of maintain strength, really, more than try and improve strength. Okay.
And then also at this point, ball, grasp training with the ball, or is same thing. You're just working the other related muscles so that you have good use of the area, and cervical and scapular active range of motion. And again, those are just strategies to keep the activity going on, and part of the success to a slap tear repair has to do with the amount of muscular fitness and going into it. So if someone's really very fit, like a sports person, and they have an injury like that, their rehabilitation will probably be a lot more speedy and effective. So then the second phase is going to be you want to go in for full active range of motion and full rotator cuff strength in neutral position. Again, the same thing here is that you never want to go too fast. You want to shoot for active range of motion, but settle for what you can, because you can really still do some damage there. Continue to protect the biceps tendon, probably the most important thing to remember there. And then begin to bring in tension after 6 to 8 weeks. I still want to watch abduction with ER or extension, and that's just one of those angles that is gonna compromise what was done by the surgery.
So why would that be? So he's talking about abduction with external rotation or extension. Why would that cause problem? Well, it's almost that insufficiency we talked, right? The biceps goes across two heads, and so you're putting that in that position. You're getting two joint stretch on that, and so you don't want to go there yet because it's going to cause extra pull, and it's just not ready for that. Okay.
And they actually go in and put a post into the joint, into the scapula, and they bring sutures out of it to fix the tendon to the joint. So that is something that you want to not tear that out before it heals. Reduction in supine and flow. There's not really a lot here that we didn't discuss. Scapular squeezes. Band resistance for IR and ER we covered. Not supinating with ER motion, that's the biceps tendon. So, and then at this point, you can use cardio for walking, stationary bike. It's gotta just not involve the arms at all, pretty much. And swimming is the last thing that'll come back in, pretty much after. Well, before we go back to this page, I just wanted to come here and, show everybody, a little,
Here, let me zoom in.
everybody thinks of slapping, that's what a slap repair is. So, James Burke there slapping himself. No theme music, but I did have Okay, phase 3. 10 weeks after surgery, your goal is full active range of motion. In this case, you're actually, you're looking for a 5 out of 5 on the rotator cuff strength at 90 degrees. You want 5 out of 5 on the periscapular strength. So really at this point, you're taking it easy, but you also want to go ahead and start working that. And you can see in the precautions, avoiding using non-provocative medium velocity. So that means if it's going to jar that joint or jar any of those tissues, probably not to do that. So avoiding falling and outside forces. So they're not really saying to avoid the usage. They're saying you want to just not do any damage at this point. So posterior glides, a sleeper stretch. Trying to remember what a sleeper stretch is. 'Cause I thought that was
It's it's the one who showed us.
Valerie.
Yeah, Valerie showed us the sleeper sets. It's where you're having them lay on their side.
Oh, right, yeah.
Just so you know. I was gonna pop up there. But just so everybody knows, the sleeper stretches, they're kind of laying on their side like so, and you have them just a little bit more back on the scapula, and then you're stretching either internal rotators or external rotators. Okay.
So we got TheraBand, cable, dumbbells, bringing those in. Since you're going for active range of motion, again, you just want to watch your ranges. TheraBand rows, just off of the door, anything where you can activate those muscles of that movement. The balance board in push-up position. I don't know if we.
That's what Alex showed us.
Yep.
Oh, did it? Okay. And so ball walkouts was kind of similar to what we were doing with the ball, except you're actually.
Ooh.
Can I use your? Have you? Oh yeah. Okay. Yeah. So you start like you're doing a push-up over this. Yeah. Sorry. On the floor, but with your chest on it. And then just walk out on it, like walk your hands forward, and then back.
Oh, that's
So, and that's really, it's engaging those muscles and it's challenging, but
It's a good mix of both postural muscles, right, and active muscles as well.
okay, that's good.
So you're stabilizing while strengthening too.
And some of these I can't remember what they were now.
That's okay. What one are we looking at?
The D2 diagonal closed kinetic chain stabilization with narrow base of support. I found a video on that and I can't.
I'm trying to think how you would do closed chain diagonal.
Kinetic stabilization.
Diagonal closed kinetic chain stabilization with narrow base of support. There was actually a pretty interesting video.
But I actually like to see it because I don't know how you would do a
Is
closed
it
chain diagonal.
Where your arms are crossed like this and your
I would honestly hazard to guess because I really don't know how you would do it closed chain. Unless you were maybe a ball.
I think it may have been a rubber ball.
A ball on the wall, I think, is the only thing I can think of that would allow that.
because kinetic is still moving.
So if you had somebody up against the
Oh.
wall,
It's like in a push-up position, and just
Brent's face.
I'm like, that's not truly closed chain. I mean, there's some closed chain elements to it. What she's doing, just so you guys know on the video, is pull up my britches so I don't show my butt. So she's going here and then swinging and doing kind of like an angle as she goes. So there is a closed chain aspect to that, but as soon as she lifts her arm up and starts swinging it, that's open
I
chain.
think the opposite arm is where the chain is closed.
Right, but you're not getting really, I mean, I guess you're technically getting a little bit of a diagonal.
Because then she's touching
As-
touching
but
the
not
other
really.
hand.
Is that why it's called closed kinetic?
Right, kinetic is just with motion.
Motion.
Yeah.
Anyway, so this is, at this point, we're really finding ways to work the angles, and work the postural, to work the surrounding muscles in concert. At this point, cardio is walking, biking, stairmaster, and running with no swimming. They go into a phase 4, and it really starts getting more complicated and finding effective exercises demonstrated for phases 4 and 5, because it's a little bit more out of the recovery, and this is more into the long-term rehabilitation and more for getting back into activities of daily living and how your activities are limited. So, I mean, the long and short of it at this point, progress slowly in what you're doing, and do what you normally do. So if somebody has had a sports injury, at this point, you're not getting into the full engagement of your sport, but you want to do actions that are related. So you want to do mild sport-related activities. And then just, we've already looked at all these exercises. And then going into phase 5, it's really the same thing. You can start incorporating overhead, throwing, overhead racket movements, swimming, that kind of thing. So I think there was something in phase 4. So it was maybe it was in phase 2. Oh, okay, inertial plyometrics and rapid exercise band drills. I didn't find any rapid exercise band drills, but like one of the things is
The bigger ball would probably be easier.
well, this was one they demonstrated it with,
Oh.
and it's just really challenging, which is the point.
That ball just is kind of flat, and so it sucks. Like, you just have to have one that will bounce a little bit to really get it.
I think it's supposed to suck. I think that was kind of what the impression that I got from. Yeah, because these are all. But it's supposed to be hard to do, and you're supposed to be, challenging yourself to. But essentially, you're gonna be calling on different parts, different muscles to try and control the ball. And your unexpected movements are gonna be really what's helping there. And there was another one with the ball. Also coming into phase 4 is you can start throwing, but not overhead. And so just having someone throw the ball to you, catch it and throw it back at this about 90 degrees. And that's working your posture. If you come from different angles, you're working your posture and you're working these muscles too. So it's engaging the trunk and the shoulder.
The other nice thing about those kind of exercises as you move into, with this stage 4, but with other stuff, this would be more like stage 3, is that you're starting to do more realistic day-to-day activities. What happens sometimes is PTs kind of forget and PTAs kind of forget to go, well, I'm strengthening them, and they've got full range of motion and they've got strength. But there's something very different about just plain general plane or anatomical plane movements versus I'm going to have to jump around all these different places in kind of almost ballistic movements, so to speak, and getting somebody ready for quicker day-to-day activities. A lot of times if you get somebody kind of back together and they're strong in those general plane, anatomical plane movements, and you're good to go, they'll go out and start doing like this all of a sudden, and they haven't done any of that. You'll get muscle tears and sprains and strains just because their body isn't used to those kind of pressures again. And so that's where you kind of want to move into those type of actions.
And that's it.
Good. Thank you, Eric. All right. So next will be medial epicondylitis. Do we have medial? You'll find that this is super similar to lateral epicondylitis, right? It's super
It's
similar.
just what sport you're playing.
Pretty much.
Tennis or golf?
The precautions are.
She put golfers. You did.
The precautions are heavy lifting and carrying, opening doors with like circulation, pronation, and flexing of the wrists, and handshaking repeatedly. That's where the ulnar and radial deviation is at, and avoid excessive gripping. And I'm not too sure about contradictions.
This is just inflammation, right? So what kind of contraindications would you have with inflammation? So you wouldn't want to heat it. Somebody else. Contraindications with inflamed.
You don't want to stretch it.
Right, we wouldn't want to do any stretches. Good. What else? We probably wouldn't want to do what type of range of motion? No active range of motion, maybe not even any active assistive yet, until that inflammation and pain go away. Okay, so no stretching, no active range of motion, no active assistive range of motion, and no heat, at least for a decent amount of time till the swelling and the pain go away. Those are really the main contraindications with any type of injury or inflammation. Okay.
So phase 1, there wasn't really any phases to it, just like as he said, as long as the pain is still there, you want to isolate the wrist for a while and use rice. So rest, ice, compress, and elevate. Sometimes they're using medications for it, and with the brace they use a Sorola. And for modalities, they're using ultrasound or non-thermal, and cold pack and ice massage. For strengthening, they're using isometric and stabilizing against resistance. So this is like pushing against on this hand and on the back side. And for phase 2, they're still on medications. They're weaning off the brace, and this straight with the flexor muscles. So you can use strengthening with isometric and slowly moving to concentric. So then you start using the wrist flexion and supination and pronation. You're still on non-thermal ultrasound and cold and ice massage and massage of the belly of the belly of the muscle. So you're here and your index finger and your third finger are basically going. Some of the exercises for phase 2 is squeezing, like this, just to isolate the wrist, or the ball. And finger opposition, just like this. So you're still using the flexor muscles when you're doing opposition, right?
Yep.
Okay. And then for phase 3,
She's like, get on your job.
this is for the
Give you one
hands
thing
and
to do.
sides, so you're using stretching, finally using stretching. So you're stretching the wrist extensions. One of the stretches that you can use are here, and then leaning over. And then this one here, or can you do this one?
Mhm.
Yeah, that one.
The other good one that they talk about is the praying stretch, where they put them here. So you're putting those flexors on a stretch.
Unless you have carpal tunnel.
And then strengthening with concentric
You
and
can still do it.
gravity
After
with
Jeff.
concentric.
Just have to wait.
So you're using 1 pound, and that one was just like supination, like this with the wrist. Then supination and pronation is here, and then isolating using the head of this one here. The other one you can use is the bands.
So just real quick, when you have them do the one where the weight is up partially out of the hand, just be really careful that they go slow, because what's happening? You're getting a stretch, right? And if they bounce back and forth, what are you doing?
Irritating.
You're ballistic stretching. You're going into a ballistic stretch. And so make sure they're very slow and deliberate in that, so that it's an actual stretch and doesn't go into that more ballistic stretch. Okay? Yeah. Yeah, you do. When they go down, you want them to go really slow. Hold it for 1, 2, 3, maybe 4, 5 even seconds, and then go back the other way.
And then the other one is you can hold this down here, stepping on it, and then pulling like this. And then the other one for supination and pronation resisted is here. And then the other way is here. Yeah.
Right, you just flip sides.
Yeah.
One's top, one's bottom, and you just. So the way to do any TheraBand thing is just think about, okay, what's that action, and then make sure that I'm doing it to where it's already tight. So it's almost like that concept of active and passive insufficiency that we talked about. Get that band on a stretch, and then add extra stretch to it.
So yeah, it's just the opposite of lateral epicondylitis. And then here you can use hot pot climbing. And with home exercises, you just kind of use different techniques, like using a tomato soup can, or for squeezing, you can use the towel squeezes, like roll it up and then squeeze it like that.
Just another one that you can do, and you can do this later on with the feet too, but you can just have a towel here and literally have them roll the towel up as they start kind of doing that. It's a very good beginning active range of motion kind of stretching exercise. So just have it out, roll it up. Okay, you can even have them unroll it back where you're not imbalancing the opposite, right? The agonist and the antagonist. Roll it back up. Okay. Good. Any questions? All right, so just really quick, I just want you guys to see this. Thank you. They make these bands, and the video I put up on either medial or lateral epicondylitis from Bob and Brad, the two most famous. All right. I heard that like 80 times in the last. So,
Yeah.
They make different ones of these. They actually make ones that have ice in them for initial. Like you take that little cold pack and you can wear it for an hour or two to kind of reduce. But you have to be careful. This one is just a bladder of air, and what it does is it just puts pressure on that part of the muscle, and it helps kind of relieve pain as you're using it, and it kind of prevents you from overusing that. And so you'll see people wearing these some, and you may even get prescribed one. You just want to make sure that you put it right over basically that epicondyle or just below it to where it's putting pressure on those muscles. Okay? All right, so next would be what? I think that may be the only forms that we really go over. It is, so next is carpal tunnel.
Carpal tunnel.
Carpal tunnel syndrome.
Alright. So who can remind us about what carpal tunnel is?
Like the impingement of the nerve, the median left side.
So yeah, so do you remember the three muscles that kind of run through the profundus and the pollicis, flexor pollicis longus. Yeah, and then the median nerve. So basically, an impingement, specifically, most oftentimes it's the median nerve, but it can impinge any of those four structures that go through. And it can be really uncomfortable and painful. So do you remember what test we can do to find if somebody has carpal tunnel? And do you remember what that is? Fallon's. And they also said that you can do Tenel sign, which I didn't know that, but that is another one that you can do. That was the tapping between the ulnar group here to see if they have that radiating sensation going down there. So there is a little bit of a difference between carpal tunnel, obviously, because it's your wrist, so you're not having any shoulder really complications, so that's a little bit of a benefit because you can move your shoulder a lot more. But the thing with carpal tunnel is that you really have to watch somebody's like ergonomics. You want to really educate them on like proper positioning. People that generally get carpal tunnel or people who are typing, using their wrists a lot for their jobs. It even said like construction workers will get it because of the positions that they're holding boards or holding their hammer or whatever it might be. But you really want to educate your patient, and I think that's a big part of their whole healing process, is making sure that they're not going to go back to what they were doing before. So contraindications and precautions was a little weird, I thought, actually. But I'll kind of explain some of these things. So the pronounced thenar muscle atrophy, so these parts of your hands here, specifically this part of your hand is going to be really atrophied and really, the muscle is going to go down in that. If a patient ever experience is greater than an 8 out of 10 pain during either your exercises or maybe if it's just like a stationary pain, you don't want to do anything. And I know sometimes patients can be like a little dramatic, but you just have to go with what the patient says. If they say it's an 8 out of 10, then just
Just don't tell the patients that, okay? Like, that's the thing is like if you tell them if it's an 8 out of 10 pain, then they'll go, oh, it's 8 out of 10, okay? But just say, this shouldn't really have a lot of pain as we do it, and then say, okay, what's your pain at? If they say 8, that's when you go, okay, we need to stop.
was, so I was gonna have you maybe explain that. a
Which
little
one
bit.
was
It says loss of finger dexterity.
Dexterity is just that movement with the thenar muscle. So what, like this is what muscles make the thenar eminence? You guys know? The brevis muscles of the thumb, basically, and so
the
it.
anatomical muscles, the anatomical stuff, muscles, that kind of
Nope.
no.
No, because the anatomical stuff box is up on top, right? So the thenar eminence is flexor, but it's the brevis ones right here, right? It's abductor and flexor brevis, I think, both. So they're technically intrinsic muscles is what they're called because they're isolated to the hand. They don't extend past the hand. They're just within the hand. And so what the dexterity is just the ability to move the thumb basically in opposition and in flexion. Okay, so abduction and flexion really are the ones that are affected by that. And so dexterity is just movement of that. Thenar dexterity.
So I was thinking for these next 2 points that I'm going to cover, I think it was before they even have surgery, if these things come back positive and they're coming to you for like pre-surgery therapy, if these things are positive, you probably want to just discontinue what you're doing. But the I don't know if I'm saying this right, Semiz-Weinstein monofilament test. So basically what they do is they have this little tool, kind of looks like this, and it has this tiny little filament thing on the end of it. And they go and they touch your thumb, and then they touch your ring finger, and then you tell them when they're touching. So they're not looking at it, and if they can't fill in the median nerve distribution, but they can fill in the ulnar nerve, then you know that it's positive. The other test, which was loss of 2-point discrimination. So the doctor has a tool that kind of looks like a prong that goes like this, and it has these 2 points. And what they do is they, again, go to your fingers, and they'll even go to your palm, and they'll touch with one of the prongs, and then they'll touch with 2 of the prongs. And then you have to say, you touched with 1 or you touched with 2. And basically, they're just seeing your sensation and things like that. Another contraindication would be patients who can't tolerate taking NSAIDs. That's a big part of helping with the inflammation that happens with carpal tunnel. So if they can't tolerate it, then you probably don't want to do lots of exercise or stretching with them.
Yeah, you got to go slower with them.
Then just some other things is just being able to, you want to check for the patient's cognition. If they're not capable of retaining information that you give them, then you probably don't want to send them with HEP because you don't want them to do it wrong. You want them to do all of their exercises within your facility. And then if ever their condition becomes worse, you want to notify their physician and send them back to their doctor. Discontinue. But getting into phase 1, it goes a little bit faster than most of your shoulder surgeries because it happens within days. So post-operative 1 to 10 days for phase 1, you're going to start just making sure that the surgical site is protected. They're going to have stitches. From pictures that I've seen, it was like across here and then maybe sometimes in the hand right here. But they are going to have stitches, so you just want to protect, make sure it's clean, that it's not getting infected, and then monitor the drainage. But the thing about it is that you can work all the extremities around it. So you're going to start doing active range of motion with the shoulder, with the elbow, and then supination and pronation. It did talk about finger and tendon gliding, which I had to look up what that was, so I'm just going to show you. So you start with this position, you go to flex the fingers, then you go to flexing like the NCP, and then you put it flat, and then you make like a duck. So it's straight, bent, more bent, flat, duck. And that is something that you can send them home with to do at home. I don't really know the purpose of it though.
The purpose is like because of the inflammation, that's the flexor retinaculum is actually part of what causes that to get tight and causes that carpal tunnel syndrome, right? It's the compression of those 4 things going underneath the flexor retinaculum, right?
Mhm.
And so the tendon glides allow you to make sure that those 3 tendons are still moving and not bunching up and getting tighter in there. If they don't move that entire time, it's too easy for it all to start kind of binding together. And so those exercises allow you to basically, and it goes back to that active and passive insufficiency, you're starting to get those on a little bit of a stretch, but not in a way that's really gonna, because it's only the lower digits, you're barely putting on it. So it's kind of just a really light, mild stretch to get those tendons flowing in that flexor retinaculum. Make sense?
It kind of reminded me of when you were in like grade school and they had you do like this thing. That's kind of what it reminded me.
That,
Finger
those,
blast.
those really are, except you're doing it basically with all your fingers. If you just did finger blasts, that really is pretty much tendon gliding, because it's just such a light flex and use of those. It allows those tendons to keep flowing in there.
Yeah, and there was like through my research online, there was different variations of how you can do tendon gliding. So I'm guessing it's just based off of either the doctor or what your facility teaches. They might have like a paper that shows you the exact movements you're supposed to do, but sometimes it's
The ones she just showed you, though, if you look in your orthopedics book, the exact same ones are what they recommend.
So there was a phase 1A. I put it on the back at the bottom, so sorry. I did say phase 1A is on the back, so hopefully that doesn't confuse you guys. But this is moving into the next like 10 days after their surgery. You can start doing, after that inflammation has gone down, you can start doing the hot pack, ultrasound, electrical stimulation. It says cryotherapy, but I'm guessing if they have inflammation still.
Well, and sometimes at the end you might like start with a hot pack to get things kind of moving. You might finish with a cold pack to kind of like settle everything down and prevent soreness and prevent inflammation.
Retrograde massage. I don't know what retrograde massage was.
I think that's talking about cross, but I haven't actually heard the retrograde term. Let me look it up real quick.
But then
Keep
there's
going, then I'll.
The pain-free ISO, which Eric already showed us like a really good one, since we're only working the muscles around it. So with the shoulder, you could start doing like the against the wall with the towel. You could start doing the flexion, the extension, abduction, things like that. For the pain-free ISOs, or however you want to do the ISOs. And then it says you can start putting in active range of motion for wrist extension, and then radial and ulnar deviation, and then no flexion until 3 weeks after surgery. So we're holding off on flexion a little bit.
So retrograde massage, and I just hadn't ever heard that term, is just kind of like that lymph drainage that we talked about massage. And I'll show you on Katie here real quick. It's mostly for the hands, but when they have inflammation, you're just kind of slowly, lightly massaging and pushing fluid back up out of the hand and up towards the rest of the body. Okay.
Another thing I talked about was the scar desensitization, which I'm glad Brett just talked about with Eric. So that's just like getting them to recognize the nerves rebuilding and things like that, because obviously you're right there. The median nerve is right where the carpal tunnel is, so. And then just mobilization of the median nerve, and then making sure that they're keeping the neutral wrist position with everything that they do. They even recommend like wearing wrist brace at night, like when they're sleeping, so that they're not putting themselves into those types of motions. But you can put that on the phase 2.
I was on it this time.
So phase 2, you're continuing to do the modalities from the phase before, still doing the scar desensitization and the retrograde massage. You're starting to progress the active range of motion, so maybe adding a little bit of weight to what they're doing with their shoulder and their elbow. It does say here that they can start doing weight with the pronation and supination, which is what Shalane just showed us with the little 1 pound weight here doing pronation and supination. There is also like TheraBars that you can do that with too.
You know, and I don't think we do, and I wish we did because they're super cool. but I really don't. I actually looked in there and I haven't seen them. They look like churros, honestly. Okay, and there's different colors of them, and it works just like TheraBands, but they're TheraBars. And I'll pull up a picture here and show you just in a second. But the lighter colors, obviously, like yellow, are easier for them to bend. Okay, and you can like use them like a towel to wring back and forth. You can do squeezes with them, both for pronation and turn them over and go the other way for pronation and supination. They're really kind of cool. You'll see them a lot. The OTs will use them, but we really should actually have some. I'll pull up a picture here while you're going though and show you guys.
You could use like the TheraBar instead of using a weight. It's just like a substitution for weight. It talks about you can start adding in active range of motion for wrist flexion now. So that's like adding a little bit of weight to extension and flexion. It says putty exercises, which is just these little containers of putty, and you can have them squeeze them. I also heard of having and have seen therapists put like pennies in them, and then the patient has to go in and like pick them out, and then you can like squeeze them too.
It's a really common thing for them to put either pennies or like beads that you can stick in there and push in there, and then they're having to use more of that precision grasp and strengthening to get through it as well.
I think isn't there different resistance for all the different colors too, Brent?
Yes.
Same
So like
colors,
they
right?
get harder.
Yes, and I believe they all work the same way. The lighter it is, the easier it is to manipulate. The darker the color, the harder it is to squeeze and manipulate. So just real quick, we'll zoom in here on these. These are what the TheraBars look like. And so even the same colors as TheraBands, there are off-brands, but the concept still works exactly the same, kind of lighter. And you just use them for rolling and flexing. They're really pretty cool. We use them a lot, actually. Oh.
So then your isotonics is just your eccentric and concentric contractions. And then this is where the education comes in, so the modification of ADLs and ergonomic education, making sure if they do have that type of job where they're typing a lot, you're making sure their desk is appropriate so they're not stressing that carpal tunnel any longer. And then you're still progressing with like the flexion and extension. There was one exercise with the TheraBand that I thought of last week that you guys, when you guys were going through the shoulder, it's called like a wall clock, and you could just have them do like go up and out and then down like that. So it's just like they're going to like 12, 3, and 6 or something. Whatever times you want them to go to.
And honestly, as an advancement of that, you can start calling out different times, so they're having to think about it and go in multiple different directions. So, just so you know.
Just make sure you know what time, like where it stands.
And not a digital clock either.
My clock is different. So phase 3 is 6 weeks to even a year later until the scar matures. You're continuing the exercises and stretches from phase 1 to phase 2. Progressing upper extremity strength, so adding in like doing the TheraBand stuff, everything that you guys have already said. Emphasizing endurance, what would you do for endurance versus strength?
More reps of lighter weight. Less resistance, more reps for endurance.
And then getting them back into that return of work, maybe adding in some exercises that they would have to do, like reaching across their desk, making sure that they're sitting in those right positions. It says even like evaluating their work, but
Sometimes you will. Doesn't happen a lot. We go on home evaluations more often, and we'll talk about those. Like Christina may actually talk to you about them in.
she did.
Oh, okay. So you will go, and they don't call them home evaluations. Did she tell you that? Okay. Just know that, like, when you go on them, they won't call them home evaluations, because what are we not supposed to do?
Evaluate.
Evaluate. But they don't want to pay a PT to do it, so you'll go on a home visit. You'll do all the things you would do on an evaluation, but you'll do a home visit. You might do a work visit. I've even taken people to actual, like, grocery stores and done a community visit, like, to see how they're able to work in the community and whether they're ready to leave. So sometimes you'll just go with them and go, okay, now we're at your workstation. Show me how you sit. You look at their ergonomics, you go, we're going to have to change this, and this is part of what's going on that's causing all this. So just know that there are times you will have to do those things. Home visits are very common, and depending on where you're at, I've probably been on hundreds, honestly. Other types of visits I haven't done very often at all.
So just going into the stretching, Brent actually posted a video from Dr. Joe that I had seen. I found it on YouTube and then you posted it. I was like, oh good, I used the right one. But she just talked about you could do like active stretches, so having the patient like sit like this and then just having them do extension, flexion, and just have them start stretching that way. And then they could move into even like doing a manual stretch and putting it into that and going this way. Did I just no. And then even getting like radial ulnar deviation, so sitting and doing the same thing but just going in this direction. She talks about the prayer stretch, which is just starting here and then coming as far as you can, stretching your wrists.
So the key with a prayer stretch is not just to kind of move it down, but to move the elbows out. Does that make sense? Okay, because it's not about coming down, because if you come down, you're really not putting more of a stretch. Make sure that you're bringing the elbows out and higher, because you're forcing more of a stretch that way.
And then she said even depending on what caused your carpal tunnel in different situations, you might want to do like a pec stretch. So that was she just showed this one where you're bringing the hands behind and pulling everything back and stretching your pecs out. She talked about some cervical stretches too, just depending on what causes your carpal tunnel.
This is important. There will actually be a question on test 2. Okay, that's like, you've got a patient and it's going to show a picture of a stretch and it's going to go, what stretch is this? Okay. If you pay attention, it's actually already one we've gone over, so you should be able to discern that. And then it'll go, why would this be important for carpal tunnel? And it's because, like, the whole body, if you got bad posture, it's going to be easier to get into bad posture here. If you got bad posture here, it comes everywhere down. So fixing posture up here can help treat, just like Dr. Joe said.
She's a smart lady.
She is.
So then just home exercise programs, which is the tendon gliding that I showed, isometric strengthening exercises. So even just having them like hold their own resistance, going into radial deviation, ulnar deviation, flexion, extension, just having them do it at home. And then grip and pinch, you can have them do like a ball, squeeze, even picking up like paper clips, like the grips that he just showed us in our notes. There's like the difference between this one or having them grip different ways and picking up little objects. The only other thing that I wanted to mention is that it can be managed non-operatively. You follow the same thing that you would do if it was managed with surgery, but that is an option.
Most times now, hopefully they will, unless it's really, really progressed and they've got some like shearing and tearing and pretty bad stuff going on, they will send them to PT first to see if we can get it fixed and get those tendons flowing and everything going again first, just because it's a lot less. And you know, there are surgeons that, I don't know, I just something to know, okay? Don't ever just go to a surgeon first, okay? Go to your general practitioner first and ask them what they would have you do, because generally they will go and tell you go see a PT. Surgeons, how do surgeons make their money? By doing surgeries, okay? And I have seen people that literally didn't need surgeries that got surgeries, okay? Especially even for things like backs. I've seen people that were getting back surgeries, and then we'll talk about it later, when really what was going on is they had a tight piriformis, and if they just had done some stretching and a little bit of strengthening, they would have been fine. And so they did the surgery, and they're like, I'm still getting tingling pain in my leg. And they're like, I don't understand why. And the surgeon's like, I don't really understand why either. And they send them to PT, and all that was going on was a really tight piriformis muscle. So just a word of caution, okay? Don't ever just go, I'm going to go to see a surgeon, because, I mean, there are people that can and will do that. And there are unscrupulous surgeons who will go, yeah, I'll do a surgery on you, because they make thousands and thousands of dollars. And the more surgeries they do, the more money they make, right? And so they're not supposed to do that, but there are people that do that, okay? So just always try and see if there's a PT option first for you or any of your loved ones, okay?
But that is it.
Okay, great job.
And I did spell some words wrong in there, so I apologize.
I won't deduct a whole lot for that. So just another thing to know, another activity that's fairly common, and we've got some of them here, for anything involving the hands and fingers. Talk about the putty. They have beads, okay, that you can put on a string, and then have the patient having to try and work with and kind of thread that. Getting those actions. There are peg boards where there's little pegs and you have them put in different patterns that we have. I didn't get that out. Blocks that you can have them take and stack. Here's the designs, the different designs for the pegboard, and you just say, this is the design I want you to do, and then in there's a pegboard, and they have to put those pegs, which is just good to get those movement, those more,
Test your brain.
right, test your brain a little bit. These become good also with neurological issues too, when people have had strokes and they're trying to learn how to process it again. You can kind of help them with that, and so those are really good. Another one is you'll see OTAs have them, and we use it too, like a bucket of rice, where you can have them put their hand in and use that as resistance. The rubber bands that I kind of talked about last time, you can do. But they'll hide stuff in the rice and have them kind of have to dig through the rice for the resistance. You can also just have them do flexion and extension exercises with their hand held down in the rice.
How do you document picking items out of rice? I mean, is it
You would
patient picked 12 beads out of rice?
Well, you would just say use of retraining of precision grasp for like whatever fingers. So what you emphasize is that you are doing something complex and that is therapy related, okay? And so you wouldn't just go, oh, I had them digging rice, because they're like. But you would go resistance, of flexion and extension while picking items out of, a resistance material. And you could even say that it was rice, but you want to make sure you word it in a way that's about using that in a therapeutic way as resistance, as you're doing.
Would you progress them by increasing the number of items?
Right, you might have them do more items. You might, there are some people will do it. I've seen PTs, not PTs. I've seen OTs and OTAs that will do it by, they have different levels of rice. So you start out with just a little bit, and then they have different containers, like thicker, so that it's more rice with more resistance and things like that. Just kind of depends. All right, so rheumatoid arthritis is next, and that's, I think, it.
Okay.
I can't have, okay.
Red's kind of crowded. So.
Okay, so rheumatoid arthritis is just a chronic inflammatory disease, and the body's immune system attacks itself. So you're going to have stiffness of joints, painful/swollen joints, fever, loss of joint function, redness, warmth, and tenderness in the joints. So for precaution, precautions, you wanna use exercises that don't cause excessive stress to the joints or bones. Dosage of stretching and joint mob techniques used to counter contractures or adhesions must be graded carefully. And then for contraindications, you don't wanna stretch over swollen joints. Vigorous stretching or high velocity thrust, move, and lift techniques you wanna stay away from. And they don't really have like different phases.
Not really. This one's unique, and I'll let you finish, and then I'll talk about it.
Okay, so you have like, what do they be called? Like 2 different phases.
Kind of. Basically, there's two.
So you have exacerbation or flare up, and for this you want to conserve your energy. You want to do joint protection, which means you want to avoid prolonged static positioning. You want to do therapeutic modalities, and they use what they call PRICE-MEM, and that's protect, rest, ice, compress, elevate, manual therapy, early motion, and medications. And then they do joint mobs, but you want to do grades 1 and 2 only. And then they have functional training, and then they want to increase/maintain the range of motion. And then they have remission, which is your subacute and chronic phases, and that's just improving the function, flexibility, muscle performance, and cardiopulmonary endurance, so doing like swimming or bicycling, and that's just as much as the patient can take. And so they have different exercises you can do. So you can make a fist, you want to hold it for 15 to 30 seconds and then release. And then they have the finger stretch where you put it on the table and you kind of make like a little cup and then you push down. And you hold it for the same 60 seconds. And then claw stretch, kind of make a claw. And then you can do different like grasping techniques. You can do the ball, and pinch,
Pulp to pulp.
and then you can do finger lifts. You just lift every finger one at a time. And then thumb extensions, you just do extension, and you can put a little rubber band on it, kind of like your TheraBand. And then just thumb flex and thumb touch every finger.
Oh, that's the touch everything.
And then you can like play with clay, just basically anything that gets that hand moving. And you want to basically avoid stretching, especially when you're inflamed. It's like a contraindication. And if you're having problems doing it, you can warm up your joints first, and then do your stretching, like your exercises.
So paraffin, if they're not in that acute stage, you might do that. One of the values of paraffin, is that you can have that hand in it, and as long as they're being super careful, you can even have them start trying to do a little bit of stretch in it until you start, as long as you're not lifting it out, but if you're keeping it in it, you're not cracking the paraffin, right? Good. So the key with this is just understand that it's a chronic condition, okay? And the weird thing about it is you'll go in and out of acute phase, okay? Like they'll have, 2 or 3 days that are great, no pain at all. Then they'll have 2 or 3 days where they're swelling again and the joints are getting attacked. What causes it is it's an autoimmune disorder where the body literally starts to eat its own connective tissue and joints, okay? Usually starts in the hands or feet and then slowly moves up. It literally can actually kill people because the body will actually eventually even start attacking its like the heart and lungs and things like that. So not always does it progress that far, but it can. And sadly, it can even happen in juveniles. There's juvenile rheumatoid arthritis, and you might see some juveniles with that. Some kids who have it and just kind of know that. And it's that process of just being really careful when they're in that acute stage. You're just doing passive range of motion. You're making sure as much as they can they're keeping that hand in a neutral position so that it doesn't like get stuck until you can move into stretch. So just like the other ones that we've talked about, in that acute phase, what do you not want to do? No stretching, okay? No heat, no
Active
Active
range.
range.
Good,
or
no
active
act,
assisted.
yeah, no active or active assisted range of motion. So you might do some like light passive range of motion with them. You might do possibly some light muscle setting isometric exercises, but you don't want to like have them doing actively too much. You want to ice it. You want to kind of help them get through the painful times and then move on. It's kind of weird. Sometimes those phases can like last. Like you can have a down phase for a year and then all of a sudden have really bad attacks and then it'll go away for months, or years. You never know. And they don't fully understand exactly what causes it. Foods that cause inflammation, though, you want to really stay away from. Sugar, processed foods, meats that have been processed, where they add a bunch of chemicals to them, bacon and ham and things like that. They think there might be some relations in those things too. Just kind of. All right.
Often gluten.
Did anybody get missed? Okay, Satchel. I think that's it though, right? Oh, okay. So we got 2 left and then I think we're good. So we'll finish these, we'll take a break. I'll copy them and then we'll come back and we'll practice these. Start.
Drop a keynote.
What?
Diamond. Can I drop a keynote?
Sure. Yeah. Let me switch
Is there a USB?
over.
There he goes again. Outdoing all of us.
It's not-
I just made a paper. Whatever.
I would have done that. I don't know.
That's not a good sign, actually. You might have to turn it off and turn it back on.
I think it's
because-
been doing that since yesterday.
So,
Maybe a reboot.
Just
huh?
kidding.
Didn't they come in and fix it?
Put it up on your phone. Just set the phone under the thing.
yeah? Can you do that? Is it
I don't know if I
available?
can transfer it to my phone, the
Oh.
keynote.
Oh, well.
Look, want to go to the classroom real quick? Let's go to the classroom real quick.
Gosh, special overachiever. Just kidding.
Here we go to the classroom.
Everybody else has to
There's AP doing Swiss ball exercises while we're all headed to the classroom.
Wait, you taking a video?
Should do a vlog or something. Everyday life in PTA.
Free candy?
That's inflammatory?
So is it.
Like, lots of things.
Milk, eggs. There's a whole list.
Eggs. Eggs get a bad rap. They're not, they're
Protein. They say they inflame the gut.
Here's Satchel waiting for the computer to reboot.
Lettuce, cheese, and nothing.
Give them a plate.
Also, then I guess I should stop eating salads. It's just bad for you. Bad.
In general, if it's natural, you're gonna be okay with it. It's not gonna cause you lots of issues. If it's not very natural, it's gonna mess you up.
Because they're linking a lot of like autoimmune
Natural.
diseases to like inflammation of the gut. And so these people, once people have an autoimmune disease, have multiple or will eventually get more than one
Yeah.
autoimmune disease.
And like they're really tracing it a lot to food and to the gut. But mostly in general, I mean there's a few exceptions, but if it's natural, like if you could grow it yourself, tomatoes, apples, beef, chicken, even cheeses for the most part aren't very processed as long as you're not getting colored cheeses. Okay?
That's the best cheese.
They make literally like, just know this, okay, just a little quick history. Cheese actually doesn't have color naturally, okay? Like even cheddar, they make white cheddar, and it's because all they did is over time, because cheese used to look a little weird and funky, so they changed the color of it so that it would last longer, so you would eat it longer. And they added dyes and stuff to it. So the cheddar, that's not what, there's no orange milk that comes out of cows, okay? So it's not like, just know that, that's stuff people have done for
Although-
whatever dumb reason.
Although blue cheese is really blue.
All the good stuff is really expensive and all the bad stuff really cheap.
That's a better question.
Why isn't it the opposite way around?
Except we're the only country who does it.
Why is the skies blue?
For like organic.
Why is trees green?
Yeah.
It's because they have to go through, like, the government makes a really hard process, packed with fees and restrictions and things like that, so it drives up the cost.
For everything.
We'll take another here.
How does the deposit tracker end work? I don't know, it just
Really,
does.
it's organic, they say it's organic, it's probably just the same as everything else.
Well, it just depends, right? Actually, it depends on, but they've changed the standards on that. If they call it organic now, it has to be checked, actually. It didn't used to be, and so there were ways to kind of get around that, but it actually has to be checked now. That is why they have to make it checked, because they have to have somebody come out and decide to make sure that they truly are organic.
Man, I should be
But I have all kinds of ideas how you would fix that there.
You have your own bakery.
I can be I'll be your Doug.
Okay. Sweet honey brownies.
I don't-
Use cows too, give them
It was here.
taste better.
Yeah, I guess I'll just do it. Alright. So you're ready to play? Yeah. Alright, let's give Satchel our undivided attention, okay?
Alright, people, so, I had cold leaf fracture. Go ahead, switch to the next slide. So what is it? Cold fracture is just complete fracture of the radius bone. It's, most of the time you see it in the radial head, like Brent was saying earlier.
Distal, it's the distal radius.
Distal radial head. Most of the time it results in a upward or like a posterior displacement of the radius and obvious deformity. So in the picture you can see this guy's wrist is obviously deformed, going up. It's not straight like a normal wrist.
All jacked up.
Yeah, you can definitely tell in the wrist there's some deformity there. So Colles fracture management. Managing a cold fracture depends on really the severity of the fracture. Undisplaced fractures of the radial bone or the radial head can be treated with a cast alone. It can be immobilized with a cast alone. Surgical options that can be performed or that you can do when the fracture is non-displaced or is displaced in this one, so that you can definitely see the displacement at the radial head. Options for that can include external fixation, internal fixation, percutaneous pinning, and bone substitutes as well. So now we get into the therapy and the treatment of it. This sheet came from Southeast Georgia Health System, and I saw another therapy session, the therapy guideline, that kind of went into different like methods. So there's a conservative management or like a conservative method of treating or therapy of a Colles fracture, and then there's also a non-conservative method or management of the Colles fracture. And what I did was I went over the non-conservative because that's what I went off on the paper. So just talking about post-operation days 10 to 14, so week 2 therapy. We're going to begin with the patient in a cast. Obviously, they have short arm cast, long arm casts for it. It just depends on the fracture and if it's really displaced or if it's not really displaced. Of course, edema is going to be a contraindication. A therapist or a PTA is really going to work on controlling that edema because a lot of the time the wrist is not a lot of fat, not a lot of muscle, so it can become severely inflamed with the fracture of the distal radius. So athletic wrap or finger socks can be used to be able to control that edema around the wrist, around the fingers, stuff like that. And then also active and passive range of motion exercises can start or begin with thumb, fingers, and shoulder. We don't want to get into forearm and wrist just quite yet in this stage of the non-conservative management. Also, this stage is going to be called acute stage, as we all know. For this one, 1 to 6 weeks. Main focus is controlling pain and edema, maintain range of motion of fingers, elbows, and shoulder. So those don't get tight and we're not losing that range of motion. A couple exercises for thumb stuff. Obviously the cast is not on there, so the cast might hinder a little bit, but if you get a short arm cast, it would help you to do these exercises like thumb extension, thumb abduction and adduction, and then thumb opposition. Okay. So now we get into post-operation week 6. This is going to be the subacute phase. Again, wrist immobilization splint is used to wear between exercise sessions at night. Cast is usually going to come off at this time, depending on whether the patient is feeling right, or if the surgeon goes in and looks at the injury, says, yeah, you can get the cast off, you can take the cast off. We just got to wear it for after exercise sessions and at night. Inflammation and swelling can increase slightly in this stage. So again, an edema glove can be used to help with that swelling, to decrease the swelling in the wrist. Active range of motion exercises can start too for the forearm and wrist. This is 6 weeks down the line again, subacute. So it's had some time to heal, had some time to grow back, had some time in the cast, and just different forearm and wrist exercises can be started. Also, neuromuscular electrical stimulation can be started to facilitate flexion of the fingers. I can't wait to get into electrical stimulation. That's really
Yeah, that'll be in the fall, and I think I taught that class last time, so I think I might be teaching you. It's a fun part.
I have that unit.
So post-op week 8. Again, in this stage, therapists or PTA main focus is trying to protect the fracture site still. Even though it's healed, we still want to make sure we're not breaking that site again or anything. They're going to control pain and edema like in the other stages. Edema and pain should be down, but it still could be relevant in a patient. And also this stage, sort of subacute, sort of settled stage. It kind of varied with the non-conservative and conservative management. So it's pretty much settled stage here. And in this stage, we're trying to regain full range of motion and begin strengthening of the wrist and forearm muscles. So wrist splint is gradually decreased. Passive range of motion exercises are performed in the wrist and forearm for about 10-minute sessions. Again, a surgeon must ensure that either fracture can tolerate passive range of motion. I haven't seen this too much, but I thought it was interesting. Dynamic splinting to the wrist or forearm can be started 4 to 6 times a day for 4 to 5 minutes. I actually saw a video on it, and it just helps to get that range of motion going. You can do one finger at a time into flexion, into extension. You could go all fingers at the same time into a flexion, all fingers at the same time into extension. It also helps to support that wrist and that fracture site. And then the last part of the settled stage would be progressive strengthening. That can be started with the use of putty, like Katie was talking about with carpal tunnel syndrome. You can also use a hand exerciser, like the grip I was messing with earlier. That can be used. And 1 or 2 pound weights can be used for active, passive, active, assistive range of motion stuff. Exercises like that. And yep, that's it.
Questions? Good. So just know, going back to the thing I showed you earlier that we didn't record, any fracture works like that. So if you're ever in a practical, just kind of understand there's the acute phase, then after basically 6 to 8 weeks, and then you can start working on the joint itself, okay? And then you move into stage 3, which is strength. Okay? Just kind of know that. It works the same with really any of them. There are exceptions, you know, to the rule, but the surgeon will let you know if there are things you need to do different. But just a plain fracture, that's how they're all gonna work.
So once it's healed, you can really start progressing.
Right. So once it's initially healed, you're gonna have a week or two that's mostly just trying to get range of motion and some stretching in, and then you can really start, after about 2 weeks after that, you can really start really wrenching on it and trying to get it going. Okay, make sense? Good. All right, do you wanna do yours in here or over there?
I can do it in here. A lot of the things have already been talked about.
Yes, that's.
So I have to say, I have no excuse. I wanted to have this in a nice format for you guys. But instead, you get my nice, wonderful handwriting.
It's fine, better than mine.
Okay.
Not better than mine, though.
Well.
I have the trigger finger. I thought this one was gonna be cool because, you know, you in my background. But it's not really.
Not as cool as it sounds, is it?
No, not at all. So basically, a trigger finger is, some of the things that I've read, it's about repetitive motions that can cause it. Other places that I've read, it talked about that it can be caused by things such as rheumatoid arthritis, gout, even age and gender kind of tends to play a role in it. And basically, in the flexor tendon, you're getting like a knot in there. And I actually have a picture from our module. Like right in here, going across the fingers, they consider that a pulley, but basically that tendon right in that tendon sheath kind of has a thickening in that area. And then that causes the fingers to start flexing, and it could be 1, 2, you have it even in your thumb. But then it can kind of get into that position where it can cause really painful sensations. But as someone is trying to do that, and it's the beginning phases where they have a little bit more control, you can hear some clicking or some popping, and then some real jerky movements when it comes to that trigger finger. They do say that now you can go through some of the therapy prior to surgery, or you can even have like a night splint, is that what it's called? And then that way it kind of helps get those fingers more relaxed and stretched out instead of being in that bent finger position. Going back to my sloppy handwriting again, if a person does happen to have to go through surgery for this, what that basically does is that they're gonna go into that little pulley and kind of help, like do a little cut to kind of open that up, and then they'll go ahead and stitch it. And they'll have like a little incision in that area. During the initial phases of 2 days to 10 days, the patient does have to be educated in how to take care of that wound. That way there's no possible infections or anything like that. It's easier to read my handwriting over here. They also do recommend having some like prednisone or cortisoid shots in that area prior to surgery, but if you happen to have to go through surgery, that's what's going to happen. And 2 days to 10 days post-surgery, some of the biggest things that they're going to go ahead and have control on is the edema and pain management on it. With that, you can go ahead and use like a compression sleeve for the finger or fingers if it happens to be multiple fingers. Let's see. And then another thing that they're going to do is they're going to do 6 times a day for at least 10 minutes. They're going to do some passive range of motion followed by 10 minutes of active range of motion. And that. One of the other important things is that it has to be at the metacarpal phalangeal and the interphalangeals that need to have that range of motion. In addition to that, it's also important that an individual uses their wrist in all different directions to kind of go ahead and stretch, keep strengthening those forearm muscles as well. If you guys don't know what I wrote on any of these words, let me know and I'll have to tell you what it is. So
It's really not that bad.
I tried to make it nice. should be a doctor, because I can't, I'm very sloppy. So, phase 2, on this one right here, it's important that you have scar massage as well, to kind of keep it a little bit more, what's the right word for that?
Pliable.
Yeah, pliable.
Yeah.
If we don't have that scar massage, the person could end up having some major issues, right? And some major scar damage, and then it becomes really difficult to kind of stretch it out. You also have to have the passive range of motion and the active range of motion. The major goals on that is to kind of get it to work towards full range of motion for that. At that time, the patient should still not lift heavy. They shouldn't have sustained gripping or pinching type activities as well. However, the patient should be encouraged to keep going on with light activities, light functioning activities for their hands. Phase 3, which is 3 weeks post-surgery, that's where the phases for active range of motion and passive range of motion should be sustained to full range within the normal limits. From there, the person can go ahead and start focusing on actually strengthening those muscles in the fingers. And actually, I forgot, phase 2, phase 3, heat modalities and ultrasound is some of the things that can be utilized during that time. Stretching that might be required for this, and then also home exercises. We've already touched bases on a lot of them with the other ones that were before me, Satchel, Martina, Katie, I think that was it.
I think so, that were the specific finger ones.
But it talks about having the fingerless where you have your hands down and you're just bringing it up like that. Okay. There's a couple of them, even though this writing's dirty. You can also use a towel or paper and you can kind of just bunch it up as well. And then you can even grip that, relax and grip it. I don't have any points with me, but you can also throw coins out and grip them. You can also go ahead and do the opposition and just grab all of those fingers. I don't know what we have in there, but they also have, actually, I forgot that one in. By the way, there's in our notes.
Oh, they're in our notes.
Yeah. That was one of those flex bars that Katie had mentioned. We also have the anchor size, but I thought these ones were really cool.
Those are cool.
The power webs are pretty cool because you can take that and you can grab your fingers in there and then squeeze it in, but then you can also put your fingers in there and then push them out to go ahead and work with that. And then of course it does have colors that will dictate the resistance level that it is.
So there's like TheraBand things in it? Or
Yeah,
is it
they're
like mesh?
kind of like a mesh TheraBand kind of thing for just for the hands. The cool thing about them is that, and I've never gotten to work with them, but I've seen them like on YouTube videos, is that you can isolate, you know, a finger, and so you can have them just work on one finger or all 5 fingers or the thumb. You can do flexion, you can do extension. They're really cool. They're something that I wish we had here on.
The putty too is kind of interesting because you can take that putty and you can go ahead and grip it to work on that, but you can also take a putty and you can put a hole in the middle of it, kind of like a rubber band, and you can have them open that putty up
Push it
to
out.
go ahead and work on it like that. Then you can also have them just take it and then bring it back in. With the putty, you can also have it where they're kind of holding one section, they put their finger through and then push up, and that way it also works on, I won't do that finger. It was close. But you can go ahead and do that motion as well. And then it's also taking that putty with the thumb and the fingers and pushing it down.
Good.
I have a question.
Oh,
What do
there's
they-
a question.
What do they do in the surgery that relieves it? I mean, do you know?
Yeah, what they do,
What does the surgery really kind of entail?
okay. I don't know if it's very well visible from your guys' angle, but there's like a little sheath that comes across right here. And say, for example, if this is the finger that has the issue, they'll come right in here and they can make an incision to kind of help relax some of it. I've also seen some where they've actually taken like a little rod anything more to add to that?
Well, there's different ways they'll do it. They will cut that retinaculum just a little bit loose so it'll slide in there. I know they'll also go in and literally do injections in, like they'll open it up, cut the retinaculum, and then do injections into the sheet to reduce the inflammation. They also are able to go in there and clean out some of the stuff that's kind of built up in there at times to allow it to flow in that sheet. This again, once again, is one of the ones that's often caused just by inflammation. It can be overuse, which will cause the inflammation, but it can be like she pointed out, a part of like rheumatoid arthritis and things like that, but dietary again, where you get inflammation in your hands, you get inflammation in the joints and the tendons caused by what you're eating. And so the body sees this food and this shouldn't be in our body, okay? And it has an inflammatory, almost allergic response to it, and it doesn't know where to send it because food and the response to the food is kind of everywhere, so it ends up in joints and in weak areas, and then that's when you get gout, you get trigger finger, you get rheumatoid arthritis, you get all these different kind of things.
It did mention diabetes as one of the possibilities too.
Diabetes
for
can
causing this.
do it as well.
Did you see anything about like, oh god, like, it's like a little metal piece, and it's kind of rounded and pointy on the end, and it's used to like,
Massaging.
yeah.
I know what you're talking about, but everything
You know
I've
what
read, I haven't.
We do have, they're like a rounded ball kind of at the end of it.
Yeah, and
We have something like that they're kind of like trigger point massagers
yeah.
that you can kind of use. Now we don't have the smaller ones for the hand, but I'll show you guys when we go back in there what that's like.
Yeah.
We have one of them, and you put it on the part where it's swollen and inflamed, and you try and literally push inflammation out. It goes into the massage, the retrograde massage that kind of pushes fluid out. And so if it's usually it's just in the hand and you can do light massage, but if it's deep and you can feel it like down in the tendon or the joint, you can really push on it, and you're getting into more kind of myofascial release where you're trying to free that fascia up and push that inflammation out. And that's what that would do. All right, let's head back. Well, no, let's just take a break actually for like 10 minutes, and I'll make copies of everybody's stuff and bring it back.